Bismillahirrahmanirrahim. On to the next session of our GIT unit. So we are going to talk about the vitamin and mineral absorption in this session. So starting from here, the very first point is the iron absorption. Here you can see the iron absorption. So iron is absorbed as Fe2 positive in the duodenum. This ionic form is very important. There are two forms of iron. The one is Fe2 positive, Fe2 positive, and then we have another form that is Fe3 positive, the ferrous form, and then we have a ferric form. So ferric form is not an absorbable form, it cannot be absorbed. The ferrous form is absorbed in the GIT. So the very first point to be remembered is this one. Just give me a second. Yep. So this is the first point that you must remember, that the ferrous form is absorbed in the duodenum. The absorption site is duodenum. Then we have folate. It is absorbed in the small bowel, in the small intestine, and the vitamin B12 is absorbed in the terminal ileum along with the bile salts and require the intrinsic factor. The iron fist bro. So the mnemonic is iron fist bro. So iron is absorbed in the duodenum. After that, the folate is absorbed in a small bowel, and at the end, the vitamin B12 or the cobalamin is absorbed in the terminal ileum. Clinically relevant in the patient with a small bowel disease or after resection. So there are some people who have small bowel disease, like if we have done some surgical resection of the bowel or something. So those people have small bowel disease and they will be losing vitamin B12 more frequently than folate, and more frequent folate wastage will be there in comparison to the iron. So that is clinically significant in the cases of short bowel or short gut syndrome. Then we have USMLE RX point about the divalent cations Fe2 positive and Ca2 positive are absorbed in the duodenum. So duodenum, like if you read this like that, like DOU, it means 2. So duodenum contains two positive ions, like the Fe2 positive or the Ca2 positive. These are the divalent cations and they are absorbed in the duodenum. Then we have a Uworld point. The case is that the patient with a peptic ulcer resistant to the treatment undergone gastrectomy with gastrojejunostomy. So there was removal of the stomach, and then the cardia of the stomach or the remaining part of the stomach was joined directly with the jejunum, and duodenum was bypassed. Which supplementation would you provide to the patient? The answer is vitamin B12, iron, folate, fat soluble vitamin, especially the vitamin D and calcium. So all of that is given. The vitamin B12, because the vitamin B12 requires the intrinsic factor, and if they are saying that the person is having gastrectomy, so definitely there is no stomach, and if there is no stomach, so intrinsic factor is not produced in first place. Secondly, folate absorption, the fat soluble vitamins, especially the vitamin D and calcium, all of that is, the absorption of all these things are hindered because the duodenum is not there, right? And you know that the pancreatic secretions enter the duodenum. If we are removing the duodenum, so lipases coming from the pancreas will not be there, so fat soluble vitamins will not be absorbed, especially vitamin D, and also is true for the calcium and folate. The iron is not absorbed because the only site of absorption of iron is the duodenum. Why iron also? Due to different causes. Number one cause for the lack of absorption of iron in the gastrojejunostomy. In this type of operation, that is called as a Billroth type 2 gastrojejunostomy, the gastric antrum is removed to decrease the gastrin production. A side-to-side anastomosis is then made between the jejunum and the gastric body, creating a blind loop composed of duodenum and the proximal jejunum. Iron absorption occurs predominantly in the duodenum and the proximal jejunum, and bypass of this segment of the small bowel invariably result in the iron deficiency anemia. Secondly, post-surgical decrease in the gastric acidity also diminishes the iron absorption and may contribute to the iron deficiency in these patients. The next point is Pire patches. Pire patches are very specific for the ileum. They are present specifically in the ileum. So these are not encapsulated. These are unencapsulated lymphoid tissue found in the lamina propria and submucosa of the ileum. What is lamina propria? If we say that this is mucosa, so mucosa is subdivided into three layers. The uppermost layer is the epithelium. Then we have lamina propria. Below the lamina propria, we have the muscularis mucosa. These three layers constitute the mucosa, and then we have submucosa below that. So this is submucosa. So the Pire patches can either be located in the lamina propria or maybe in the submucosa. So here they have shown a Pire patch, the paler area, like over here, and maybe over here as well. So the Pire patches, they contain the specialized M cells. M cells are present over the Pire patches. Like suppose this is the Pire patch, and over the Pire patch we have an M cell situated like that. So this is an M cell. So they contain specialized M cells that sample and presents the antigen to the immune cells in the Pire patch. The B cells stimulate in the germinal center. The B cells stimulated in germinal centers of the pire patches differentiate into IgA secreting plasma cells, which ultimately reside in the lamina propria. Like, why IgA? Because you know that IgA is the antibody of the mucosal membranes and it provides the mucosal defense mechanism, and that IgA is ultimately going to be secreted by the B cells which are present in the germinal center of the pire patches after they are exposed to the antigens which are presented by the M cells. The IgA receives the protective secretory component and is then transported across the epithelium to the gut to deal with the intraluminal agent. We'll see about this secretory component in detail when we do the immunology, but for right now just remember that IgA exists in the dimeric form in the GIT lumen. Like suppose this is one IgA molecule, and then we have another IgA molecule which is joined together with a J chain, and and that J chain is giving this dimeric structure stability. Like there is a J chain that is connecting them. And another thing, when the IgA antibody is secreted into the lumen, so during the secretion there is the transcytosis of the IgA antibody, and to protect the IgA antibody from the proteases inside the cells as well as in the lumen, there is a secretory component that is attached to these antibodies, and that secretory component is let me draw it with a different color blue. So that secretory component is derived from the epithelial cells. So this is the secretory component. We'll talk about that in detail in the immunology session, inshallah. Moving forward, the think IgA as the intra-gut antibody, and always say secretory IgA, because IgA in the circulation is of no use for the mucosal defenses until and unless it is secreted in the gut. So that is why we always use the term secretory IgA for the functional form of the IgA. Then we have Uworld point. Shigella exhibits specificity for the M or microfold cells that lie in the base of the microvilli within the pire patch region of the ileal mucosa. M cells are specifically designed to sample the contents of the gut lumen and transfer the antigen to their basal lamina within the endosomes. The M cells are specially designed to sample the contents of the gut lumen and transfer the antigen to the basal lamina within the endosomes. Like suppose this is an M cell. M cell is specialized to detect the antigen. Like suppose this is a viral antigen that is being detected over here. Suppose here we have a viral antigen, and that viral antigen was taken up by these cells. These cells endocytosed this particular viral antigen or bacterial antigen. They processed that, and then on the basolateral surface, below basolateral surface is the surface towards the blood side. So they packed the viral antigen into the endosomes and then transferred it to the basal lamina within the endosomes. Like it is transferred down. This whole thing is transferred down to the pire patches which are located below the M cells. The viral antigen encased inside the endosome is transferred to the basolateral surface enclosed inside the endosomes. Okay. Now moving forward, we have bile. The basic concept about bile is that it is composed of bile salts, bile acid conjugated to the glycine taurine, making them water soluble. So bile acids, when they are conjugated to either glycine or taurine, they become more water soluble. Phospholipids and cholesterol, bilirubin and water. So the constituents of the bile contains bile salts, the phospholipids, cholesterol, bilirubin and water. So the big threes are the bile salts, cholesterol and phospholipids, and if you want you may also remember the bilirubin and water. And ions. Cholesterol 7 alpha hydroxylase catalyzes the rate limiting step of the bile acid synthesis. For the bile acid synthesis, there is an enzyme that is called as 7 alpha hydroxylase that is catalyzing the rate limiting step. So that is why it is very important in the bile acid synthesis function. The bile functions in the digestion and absorption of the lipids and fat soluble vitamins. Cholesterol excretion, body's primary mean of eliminating the cholesterol. Antimicrobial activity by the membrane disruption. So these are the three main functions of the bile, that is digestion and absorption of the lipid and fat soluble vitamins. The cholesterol excretion, body's primary mean of eliminating the cholesterol. We know that HDL takes the cholesterol from the liver to the body, that is why it is good cholesterol, and LDL brings the peripheral cholesterol towards the HDL takes the peripheral cholesterol towards the liver, right, to be eliminated. That is why it is good cholesterol. While the LDL takes the cholesterol from the liver to the periphery. That is why it is bad cholesterol, because it can cause the accumulation of cholesterol in the arteries. Forget about LDL right now. We are talking about HDL. We say that HDL brings the peripheral cholesterol from arteries all the way back to liver. Now what does the liver do with that cholesterol? The primary mean of elimination of the cholesterol is via bile. Like cholesterol is present in the bile and bile is excreted into the gut, and that will ultimately be released in the feces. So the primary mean of excretion of cholesterol of the body is excretion via bile. Antimicrobial activity via membrane disruption. So membrane disruption also the bile also functions to cause the membrane disruption of the microbes, and when the membrane disruption happens, that result in the antimicrobial effect of the bile. So decreased absorption of the enteric bile salts at the distal ileum, as in the short bowel syndrome or the Crohn's disease, prevents the normal fat absorption. Calcium, which normally binds oxalate, calcium binds the fat instead, so free oxalate is absorbed by the gut. That increases the frequency of calcium oxalate in the kidney stones. So the thing that you must remember over here is that calcium loves to bind with oxalate. I don't know the formula of oxalate, that is why I am reading it calcium ox. So calcium loves to bind with the oxalate. If there is lack of bile and the bile is not performing its function properly, so resultantly what happens is that there is a lot of fat that is not being emulsified, that is not being absorbed, that is not being digested. So the calcium starts binding to the fat. So the calcium is binding to the fat and oxalate is free. This free oxalate will be reabsorbed, and this will ultimately cause calcium oxalate stones in the kidney. So it is very important to be remembered. Decreased absorption of the enteric bile salt in the distal lumen, as in the short bowel syndrome and Crohn's disease, prevent the normal fat absorption. Calcium, which is normally binds the oxalate, binds the fat instead. So free oxalate is absorbed by the gut. At increased frequency, the calcium oxalate kidney stones formation will be there. So here you can see the enterohepatic circulation of the bile. The cholesterol is converted into bile at a synthesis rate of 0.5 grams per day. This bile is going to the circulation. The bile acid pool, 4 gram of the bile is entering the circulation. The excretion into the feces is only the 0.5 gram, while the rest of them, which are some 3.5 grams, are being reabsorbed, because only the 0.5 gram of bile salts are being excreted in the lumen per day. So you must remember this thing. Now moving forward to the lipid absorption. The dietary lipids, for example, the triglycerides, the phospholipids, the cholesterol esters, are primarily digested in the duodenum. Why in the duodenum? Via the action of pancreatic enzymes, for example, the lipase, the phospholipase A2, the cholesterol esters. Second point is, the bile is also released into the duodenum, because we know that there is a common pancreatico-duodenum, the hepatopancreatic duct that is opening in the major ampulla of Vater. So bile is not released into the duodenum, where bile salts emulsify the end products of the fat digestion, for example the fatty acids, the monoglycerides, and form water soluble micelles. So the bile salts emulsify the end products of fat digestion and form the water soluble micelles. In the jejunum, these micelles come into close contact with the gut epithelium, which facilitates the passive absorption of fatty acids, monoglycerides, and the cholesterol across the brush border into the enterocytes. The triglycerides, phospholipids, and cholesterol esters are then reconstructed and combined with apoprotein to form the chylomicrons, which are then released into the intestinal lymphatics. It is very important point. Lipids digested into duodenum and absorbed in the jejunum. So lipids are digested in the duodenum and they are absorbed in the jejunum. Although storage and periodic release of the bile from the gallbladder helps with the digestion, particularly of the large fatty meals, the gallbladder is not essential for the adequate absorption of dietary lipids. The gallbladder is not essential. Gallbladder helps in digestion, but it is not essential for adequate absorption of the dietary lipids. In the people who have cholecystectomy, the removal of the gallbladder, those people function normally. So the gallbladder is not essential for adequate absorption of the dietary lipids. Loss of concentrating and storage function of the gallbladder after the cholecystectomy result in the constant release of the bile into the duodenum, allowing most patients to tolerate a normal diet. So loss of concentration and storage function of the gallbladder after cholecystectomy result in constant release of the bile into the duodenum, because the gallbladder was responsible for accumulating the bile until it is needed to be released into the circulation. No, not circulation, until it is needed to be released into the duodenum. But if the cholecystectomy has been done and there is no gallbladder, so the bile is not being stored, it is not becoming concentrated, it is released directly into the duodenum, allowing most patients to tolerate the normal diet. However, the continuous biliary drainage can overwhelm the absorptive capacity of the bile salts in the ileum and may lead to chronic secretory diarrhea in some patients, because the bile that is being released, only 0.5 grams per day of that is being released in the circulation. I'm sorry, okay, only 0.5 gram per day is being excreted in the stool. The rest of that is being reabsorbed. But if there is continuous surge, if there is no gallbladder, there is continuous surge of that bile into the duodenum, and that overwhelms the absorptive capacity of the bile. And if there is if there are excessive bile salts in the colon, the bile salts are osmotically active. They draw water along with them, and they will cause excessive amount of diarrhea, and that diarrhea will be secretory in nature in some patients. Then we have, I don't know how is it causing a secretory diarrhea per se, but it can cause diarrhea for sure. Then we have an NPME point. The stomach is able to absorb the water and alcohol, but is generally regarded as an organ of digestion and storage, not absorption. Although the stomach can absorb water and alcohol, but for the general purposes, for the physiologic explanations, we say that the stomach is performing only digestion and storage. We don't render it as an organ of absorption. The ileum is primarily involved in the absorption of bile salts and vitamin B12. The proximal colon is responsible for the water and electrolyte absorption, and whereas the distal colon is primarily involved in the storage of the feces. Then we have a Uworld point, that is lipid soluble vitamins are absorbed in the jejunum. Ileum for the absorption of 2Bs, that is vitamin B12 and bile acid. Now you know that ileum, specifically the terminal ileum, is damaged in the Crohn disease, and maybe it is resected in the case of short bowel syndrome. In both of these scenarios, there will be decreased absorption of vitamin B12 and decreased reabsorption of the bile acids, right? So that is problematic, and we have to do something for that. Point number from the USMLE RX, there is a point that terminal ileal resection will lead to osmotic diarrhea, steatorrhea, as the bile acids are absorbed from the terminal ileum. And if there is no terminal ileum, the bile acids will not be absorbed, and here they have written osmotic diarrhea because that makes a lot more sense, that bile acids being osmotically active, the bile salts and the bile acids, they are osmotically active and they can draw water with them if they are entering the colon. So more and more water is entering the colon, and that will cause osmotic diarrhea. I have no idea how is that causing the secretory diarrhea as mentioned over here. It would definitely be the right thing to, that is why they have mentioned here, but I don't know how is it causing secretory diarrhea in first place. That was written somewhere over here. No, it's not over here. I don't even remember where is it written now. Secretory diarrhea, proximal colon ileum, yes, and where is it? Yeah, there is secretory diarrhea. So they are saying that excessive secretion of the bile into the lumen can cause secretory diarrhea in some patients for some reasons. I don't know. Now moving forward to the next point, that is about the bilirubin. Heme is metabolized by the heme oxygenase to biliverdin, which is subsequently reduced to the bilirubin. Unconjugated bilirubin is removed from the blood by liver, conjugated with a glucuronate and excreted in the bile. Direct bilirubin is conjugated with a glucuronic acid, and that is water soluble. Indirect bilirubin is unconjugated and water insoluble. So the first point is that RBCs which are old enough or which are having some pathology, they will enter the spleen, and the splenic macrophages will cause the breakdown of RBCs into, and the heme will be released. The heme will be broken down into biliverdin, and from them ultimately bilirubin will be formed. That bilirubin will be unconjugated, which means that it is not water soluble. The unconjugated bilirubin is water insoluble, it is lipid soluble. So to move it from point A to point B in the circulation, we have to bind this unconjugated bilirubin on albumin. Like I am writing it, unconjugated bilirubin should be bound to albumin to move it into the circulation until it reaches the liver, right? So this albumin bound unconjugated bilirubin, when it reaches the so here they have depicted it. The unconjugated bilirubin, which is also called as indirect bilirubin, the water insoluble one, it is bound to albumin, and then it enters the unconjugated bilirubin. Albumin complex will enter the liver. In the liver there is an enzyme that is called as a UDP glucuronosyl transferase. That UDP glucuronosyl transferase will convert the unconjugated bilirubin into conjugated bilirubin by conjugating the glucuronic acid with this unconjugated bilirubin. And because glucuronic acid is a polar molecule, it is a polar moiety that makes this compound, this bilirubin, this conjugated bilirubin, water soluble. So this is direct bilirubin, and this bilirubin is water soluble. Now when this conjugated bilirubin is secreted into the GIT in the gut, in the duodenum, there is gut bacteria. The gut bacteria will convert the conjugated bilirubin into urobilinogen, 80% of the urobilinogen will be excreted in the feces as stercobilin, which gives the brown color to the stool. And 20% of the urobilinogen, remember, we are talking about the urobilinogen, we are not talking about the bile salts, because most of the bile salts are reabsorbed, right? Right now I'm talking about bilirubin specifically, because when we were talking about bile, we said that bile is formed where, not here, it was somewhere over here. Yeah, we said that bile is formed from bile salts, the phospholipids, cholesterol, bilirubin, and water ions. So I'm not talking about bile salts. Bile salts are reabsorbed, and a very huge chunk of the bile salt is being reabsorbed. It should be reabsorbed. I'm not talking about bile salts right now. I'm talking about bilirubin. Bilirubin is converted into stercobilin. It is converted into urobilinogen, and most of the urobilinogen is excreted in the feces in the form of stercobilin, like 80% of that. Only 20% of the urobilinogen is reabsorbed, and that out of that 20%, 10% goes to the kidney, and that is excreted in urine as urobilin, and that provides the yellow color to the urine. 90% undergoes enterohepatic circulation. It comes back to liver. It is again formed as conjugated bilirubin and then again released into the circulation. So 90% of the reabsorbed urobilinogen will be undergoing enterohepatic circulation and will be converted into conjugated bilirubin again. Now let's move forward to the next point, that is about the bilirubin metabolism. So there they have shown that this is the heme that is released from the broken down RBCs. The heme oxygenase will convert the heme into biliverdin, and then biliverdin will be converted into unconjugated bilirubin by the biliverdin reductase. The urobilinogen, when it is bound to the albumin, it enters the liver. The gluconosyl transferase, UDP gluconosyl transferase, will convert the unconjugated bilirubin into conjugated bilirubin. As you can see over here, this is conjugated bilirubin. The conjugated bilirubin is acted upon by the bacterial dehydrogenases, and these bacterial dehydrogenases will convert the conjugated bilirubin into urobilinogen. This urobilinogen will be converted into stercobilin, and stercobilin will give the brown color to the feces. The stercobilin is going to give the brown coloration to the feces. Okay, cool one. So the just give me a second. Yep, so this is going to provide the brown color to the feces. Now moving forward to the next point. Yep, so in the next point they are saying, now we are going to start the GIT pathology. So let's start the GIT pathology. We'll start with the oral cavity. Firstly, we are going to see the cleft lip and cleft palate, as you can see in this picture. The cleft lip and cleft palate, the cleft usually occur together. Isolated cleft lip and palate is less common. It is happening due to failure of the facial prominences to fuse. We know when the embryo is developing, there are a lot of like maxillary prominences there is mandibular prominence, there is frontal prominence. Okay, frontal prominence is not important, but the maxillary prominences are very important. The maxillary prominences and the palatine shelves, something like that. So if the facial prominences are not fused together during the early pregnancy, the facial prominences, one from the superior, two from the side, and one from the inferior, they grow and fuse together to form the face. If they are not fusing properly, they may result in the cleft lip or cleft palate. Failure of fusion between the frontonasal and the maxillary prominence will lead to cleft lip. There they have written it, that the failure of fusion between the frontonasal and the maxillary prominences will lead to the formation of cleft lip, right? So and also you must remember that facial prominences are one coming superiorly, two coming from the sides, and two from the inferior version. So there are total 5 facial prominences, one superior, two from the sides, two from the inferior aspect. They fuse together to form the face. If the frontonasal and the maxillary prominences are not fused together properly, they will result in a cleft lip. What is aphthous ulcer? Aphthous ulcer is a painful ulceration of the oral mucosa. It arises in relation to the stress and resolves spontaneously and often recurs. It is characterized by the greyish base surrounded by the erythema. Recurrent aphthous ulcer plus genital ulcer plus uveitis, the triad is called as the Bassett syndrome. So first you can see in this picture, like this is the ulcer with the greyish base, like this is the greyish base to the ulcer, and surrounding that we have this erythematous area like this. So they are saying that it is characterized by the greyish base surrounded by the erythema. Recurrent aphthous ulcers plus genital ulcer plus uveitis will lead to Bassett syndrome. Okay, the triad of aphthous ulcers in the mouth, genital ulcers, and the uveitis is seen in the Bassett syndrome. What is Bassett syndrome? Recurrent abscess ulcers, the genital ulcers, and the uveitis. It is happening due to the immune complex vasculitis involving the small vessels. Can be seen after the viral infections, but etiology is unknown. Then we have oral herpes, as you can see in this picture. So the oral herpes, vesicles involving the oral mucosa that rupture, resulting in a shallow, painful red ulcer. It is caused by the HSV1. So there is a rule of thumb that you must remember, that suppose this is a human body, all the problems which are lying below the waist, they are happening because of HSV type 2, and all the problems which are happening above the waist, that are caused most commonly by the HSV type 1. This is not a rule, this is just a mnemonic or maybe a rule of thumb to remember some things, but you cannot generalize this rule because there are some problems which are caused by HSV2 but are happening in the brain, right? So remember it like that, that HSV1 causes the problems below the waist and HSV2 causes the HSV2 causes problems below the waist and HSV1 is causing the problems above the waist. So gingival stomatitis or oral herpes, that is happening definitely above the waist, so that is caused by the HSV1. Primary infection occurs in childhood, lesions heal but the virus remains dormant in the ganglia of the trigeminal nerves. Stress and sunlight causes reactivation of the virus, leading to the vesicles that often arise on the lip, that is called as the cold sore. Cold sore. Now let's talk about the squamous cell carcinoma of the oral cavity. The malignant neoplasm of the squamous cell lining of the oral mucosa. It is the malignant neoplasm of the squamous cell lining of the oral mucosa. Tobacco, alcohol are the major risk factors. The floor of mouth is the most common location. For the squamous cell carcinoma of the oral cavity, the floor of mouth is the most common location. Okay. Oral leukoplakia and erythroplakia are the precursor lesions. What is leukoplakia? Leukoplakia is a white plaque that cannot be scraped off, often represents the squamous cell dysplasia. So leukoplakia is a white plaque that cannot be scraped away and it often represents the squamous dysplasia. Leukoplakia is distinct from oral candidiasis, that is also called as thrush, and hairy leukoplakia. So leukoplakia is distinct from both of these conditions, that is oral candidiasis and the hairy leukoplakia. Oral candidiasis is a white deposition on the tongue which is easily scraped away, usually seen in the immunocompromised states. Hairy leukoplakia, on the other hand, is a white, rough, hairy patch that arises on the lateral side of the tongue. It is usually seen in the immunocompromised individuals, for example, the people who are suffering with the AIDS, and is happening due to Epstein-Barr virus. It is due to the Epstein-Barr virus induced squamous cell hyperplasia, and this oral hairy leukoplakia is not pre-malignant. Remember that. Then let's talk about erythroplakia. The erythroplakia is a red plaque that presents the vascularized leukoplakia and is highly suggestive of squamous cell dysplasia. We'll keep this session till here.